Usually when we talk about a medical diagnosis, there's this underlying expectation of precision.
Right, yeah.
Like you expect it to be like mechanical engineering almost. You fall down, your arm hurts, the x-ray shows this jagged white line, and the doctor just points at the screen and says, well, there it is, broken.
Exactly. It's binary. It's either broken or not broken.
Yeah.
And it's a very clean, comforting process in a way, because we really crave that visibility. We want our physical problems to be neatly categorized and just, boxed up.
Right. But then you step into the world of cancer survivorship, and suddenly that metaphorical x-ray machine is just completely shattered.
Oh, absolutely.
We are looking at a diagnostic landscape that is incredibly murky. It's this space where the cure itself leaves scars that look and feel, frankly, terrifyingly similar to the disease.
And that ambiguity is the absolute definition of diagnostic muddy waters. I mean, it creates a massive amount of silent anxiety for patients who are just trying to navigate life after discharge.
Which is exactly why we are taking a deep dive into those waters today. We're focusing on navigating your physical health after cancer treatment specifically, life after treatments for gynecological and breast cancers. And the central question we want to answer for you today is this. How can you tell the difference between an expected, albeit really unpleasant, side effect of your cancer treatment and a critical warning sign that requires immediate specialist review?
Yeah, and to figure this out, we aren't just guessing, right? We aren't relying on anecdotal advice here.
No, definitely not.
We are cross-referencing massive clinical databases today to find the actual medical dividing line between a side effect and a siren. So we're pulling directly from the comprehensive guidelines of the British Gynecological Cancer Society, as well as the protocols from the National Institute for Health and Care Excellence, or NICE, as it's known, and some deeply revealing oncological survivorship reviews from Macmillan Cancer Support.
So our mission today is simple. We want to empower you with the knowledge to decode your body's signals after cancer. We really want to help you separate the new normal from symptoms that mandate urgent medical attention.
Right.
So that you can advocate for your health confidently without feeling like you are panicking over nothing.
Okay, let's unpack this. Because the reality of life after cancer treatment is, well, it's incredibly complex.
It really is.
Before we can even begin to identify what is abnormal, those red flags, we first need to establish what is considered normal post-treatment. We have to define the baseline.
Establishing that baseline is so crucial because for many survivors, the new normal is just a profound physical shock.
Yeah.
Let's look at breast cancer survivors first. Up to 75% of women surviving breast cancer will experience something clinically termed genitourinary syndrome of menopause, or GSM.
75%, that's huge.
It is. And this happens because treatments like chemotherapy or endocrine therapies like aromatase inhibitors, they are designed to push the body into a sudden, severe hypoestrogenic state, meaning a massive drop in estrogen.
Exactly. In literal terms, they starve the body of estrogen to prevent the cancer from feeding on it and returning.
Which is obviously a fantastic strategy for fighting the cancer, right? But reading through the biology of what that starvation does to the rest of the body is it's brutal.
It is specifically devastating to the urogenital tract. What's fascinating here is to understand why you really have to look at the cellular anatomy of the vagina.
Okay, break that down for us.
So it consists of multiple layers, including a mucosal layer and underlying connective tissue. In a healthy premenopausal state, estrogen acts as the master regulator. It helps the superficial epithelial cells plump up and shed regularly. And when they shed, they release glycogen.
Okay, so glycogen is like a sugar.
Basically, yes.
Yeah.
And that glycogen acts as a food source for lactobacilli, which are the good bacteria in the microbiome.
Right.
The lactobacilli process the glycogen and produce lactic acid, which keeps the entire environment acidic, resilient, and healthy.
So when the cancer treatments remove the estrogen, that whole domino effect just stops dead in its tracks.
The entire ecosystem collapses. I mean, without estrogen, the mucosa thins out drastically.
Right.
The superficial cells drop to less than 10% of their normal volume.
10%.
Yeah. And because there are no plump cells shedding, the glycogen just disappears. Without food, the good bacteria die off and the pH level rises.
Making the area totally vulnerable to infection.
Exactly. And at the same time, the connective tissue literally goes dormant. The collagen fibers fuse together.
Ouch.
Yeah, the clinical result is severe vaginal dryness, burning, itching, intense pain during sex, and frequent urinary tract infections.
To put a visual on this, it's less like a dry winter landscape and more like taking the mortar out of a brick wall, you know?
Oh, that's a good way to look at it.
The estrogen was the mortar holding everything together with a bit of cushion and flexibility. And without it, the cells are just grinding directly against each other.
Yes, precisely.
Which explains why the friction causes tears so easily. And that is just from estrogen depletion. If we factor in pelvic radiation for things like cervical or endometrial cancers, the baseline shifts even further into the extreme.
It does. Radiation introduces a completely different mechanism of trauma.
Right.
The acute phase involves intense inflammation, but it's the chronic phase, which can last for years, that alters the baseline. Radiation permanently damages the tiny blood vessels in the pelvic region.
Which cuts off the blood supply.
Exactly. It leads to ischemic changes, meaning a chronic lack of blood flow and oxygen to the tissues. Without proper blood flow, the tissue just can't repair itself, leading to circumferential fibrosis.
So the tissues scar, harden, and lose their stretch.
Yes.
The guidelines mention this causes vaginal stenosis, right?
Yes, the physical narrowing and shortening of the vaginal vault.
Yeah.
The skin inside becomes incredibly thin, delicate, and just very easily traumatized.
Reading this, I kept thinking about the sheer endurance of patients. It's mind-blowing. But it also raised a huge red flag for me regarding communication. Because if the tissues are literally stripped of their mortar and their blood supply, couldn't a little pain or spotting just be dismissed as normal collateral damage? I mean, if everything is dry and scarred, of course it's going to hurt or bleed a little.
What's fascinating here is that logic makes perfect sense. And it is exactly how thousands of patients rationalize their symptoms every single day.
Right.
They tell themselves, well, I had radiation, of course I'm bleeding. But dismissing that bleeding is exactly where the danger lies.
Because it masks the real issue.
Right. Discomfort and tissue fragility are expected side effects, and thankfully we have treatments for them. Things like localized vaginal estrogen that doesn't absorb systemically, or DAGA pessaries to rebuild the tissue.
Even specialized pelvic floor physical therapy. Right?
Exactly. And specific dilator protocols can drastically improve that baseline.
Yet the Macmillan survivorship surveys reveal a really staggering statistic. 68% of women who experienced negative changes in their physical and sexual health post-treatment had never even spoken to a doctor about it.
It's heartbreaking.
68%. They're just suffering in silence, assuming it's just the toll they have to pay for surviving.
And that silence is the biggest hurdle. Because while dryness is a side effect, specific types of bleeding are an absolute siren. The medical community draws a very hard, non-negotiable line here. You cannot simply chalk up certain symptoms to the new normal.
Okay, let's draw that line clearly for the listener. What kind of bleeding crosses over from expected side effect of fragile tissue to urgent warning sign?
The most critical one outlined across both the NIC and BGCS guidelines is postmenopausal bleeding, or PMB.
Okay.
The strict medical definition here is any unexplained vaginal bleeding that occurs more than 12 months after menstruation is completely stopped.
And the volume doesn't matter.
The volume absolutely does not matter. It could be a heavy flow, or it could literally be a single spot of pink on the tissue paper after using the bathroom.
Wow, just a spot.
Just a spot. If it has been a year since your period stopped, any bleeding is an immediate red flag.
Because that is the most common way endometrial cancer of the womb lining presents itself.
Overwhelmingly so. Endometrial cancer almost always announces itself with postmenopausal bleeding. If a patient presents with this, the guidelines dictate an urgent 2-week cancer pathway referral.
You do not wait.
You do not wait. You don't assume it's just a friction tear from vaginal dryness or radiation fibrosis. You get a pelvic ultrasound to measure the thickness of the endometrium immediately.
Now, the sources emphasize a massive caveat here regarding specific breast cancer drugs. Tamoxifen keeps coming up as a major complicating factor.
Tamoxifen requires a massive warning label. It's a selective estrogen receptor modulator.
Right.
So in the breast tissue, it acts as an antagonist, meaning it blocks estrogen receptors to starve breast cancer cells.
Which is what you want.
Exactly. But paradoxically, in the uterus, it acts as an agonist. It mimics estrogen.
Oh, wow.
Yeah, it can stimulate the lining of the womb to grow,
Yeah.
causing endometrial hyperplasia, which is a precancerous thickening, or even full-blown endometrial cancer.
Here's where it gets really interesting, and honestly, it's a cruel irony for the patient. The very medication saving you from a breast cancer recurrence is actively creating an environment that could trigger a uterine cancer, or at the very least, symptoms that mimic it.
It creates a terrifying diagnostic minefield. If you are currently taking tamoxifen,
or have previously taken it and you experience any abnormal vaginal bleeding, that is a strict mandate for an urgent specialist review.
And for premenopausal survivors, the rules are equally rigid, right?
Very rigid. Newly heavy periods, bleeding between your periods, which is intermenstrual bleeding or bleeding after sex, all require immediate specialist investigation.
Because bleeding after sex could just be a benign tear from that missing mortar we talked about earlier, but it is also a classic presentation of cervical or vaginal cancer.
Exactly. And the patient cannot and should not be expected to know the difference. You cannot eyeball a spot of blood and determine if it's from a benign radiation tear or a malignant tumor.
Right.
A specialist has to look at the cellular level. That is the entire reason the 2-week rapid referral pathway exists.
So the overarching rule for the listener here is simple. If you see blood where there shouldn't be blood postmenopause, between periods, or after intimacy, you do not try to diagnose yourself.
Okay.
You pass that responsibility directly to a specialist.
Absolutely. Bleeding is a visible, tangible alarm. It demands attention. But not all gynecological recurrences are kind enough to give you a visual courtesy.
Right.
The recurrences that are truly concerning are the ones that hide in plain sight.
The stealth symptoms. We are talking about ovarian cancer and pelvic recurrences here. Reading through these guidelines, what terrified me is how insidious these symptoms are.
Oh, for sure.
They camouflage themselves as everyday, mundane digestive issues.
They are absolute masters of disguise. Ovarian cancer is notorious in the oncology world for presenting with vague, nonspecific abdominal symptoms. People think they just ate something disagreeable or they're just gaining a little weight as they age.
Yeah.
But the Macmillan and NICE guidelines provide a very specific metric to help patients cut through the noise of daily aches and pains.
The 12 times a month rule.
Yes, it is called the 12 times a month rule.
Walk us through that metric, because it seems like a brilliant practical tool for anyone listening who tends to second-guess their body.
It really is. The guidelines state that you need an urgent pelvic ultrasound and a CA-125 blood test if you experience certain specific symptoms persistently or frequently.
Okay.
And the threshold they set is experiencing these symptoms more than 12 times in a single month. That is almost every other day.
And the specific symptoms being persistent bloating, feeling completely full after only a few bites of food, which they call early satiety, and persistent pelvic or abdominal pain.
Right. If those are happening 12 times a month, you need specialist eyes on it.
Yeah.
And you need that CA-125 test.
I want to push back on the blood test a little bit, though. The guidelines mention this CA-125 test as a primary diagnostic tool. I know it's a tumor marker, but if I just have a stomach bug or a weird cycle, isn't there a risk of a false alarm?
That's a very fair point.
Like, how does this protein actually work as an alarm bell?
It's a great question. And understanding the biology really helps alleviate the mystery here. So CA-125 stands for cancer antigen 125. It's a glycoprotein. Now, it is true that it can be elevated for totally benign reasons like endometriosis or even just a heavy menstrual cycle.
Right, because it's produced by the cells that line the pelvic organs anyway.
Exactly. However, when ovarian tumor cells multiply, they aggressively irritate the lining of the abdominal cavity, which is called the peritoneum.
Okay.
And that severe irritation causes the peritoneum to shed massive amounts of this CA-125 protein directly into the bloodstream.
So it's the sheer volume of the protein that acts as the red flag, not just its presence.
Precisely. The guidelines set a specific threshold, a CA-125 level of 35 international units per milliliter or greater.
35. Got it.
When you combine a level above 35 with the 12 times a month physical symptoms, it triggers a fast-tracked cancer assessment.
You know, experiencing these vague symptoms, it feels like your car's check engine light coming on, but the icon on the dashboard looks exactly like a generic low tire pressure warning.
Oh, that's exactly it.
You just assume it's a minor maintenance issue. In fact, the sources highlight a massive trap here regarding irritable bowel syndrome, or IBS.
The IBS trap. Yeah.
It's almost comical in a dark way. It's like the ultimate betrayal of getting older. You hit 50, and your body decides to throw in IBS just to keep things interesting, but the guidelines say, do not buy it.
The IBS trap is incredibly dangerous. The clinical guidelines are fiercely explicit about it. Any new onset of IBS-like symptoms in a woman over the age of 50 is a major red flag.
Because IBS is usually a younger person's game. Like, it doesn't just spontaneously appear in your 6th decade.
Almost never. IBS rarely presents for the very first time in a woman's 50s or 60s.
Wow.
So if a 55-year-old survivor suddenly develops changes in her bowel habits, bloating and abdominal pain,
Her primary care doctor should not be diagnosing her with new-onset IBS and sending her home with dietary advice.
No.
They should be looking directly at her ovaries and pelvis.
Wait, let me make sure I understand the mechanics here. Why does a gynecological cancer recurrence mimic a bad stomach bug or a bowel condition in the first place? Why the crossover?
If we connect this to the bigger picture, it comes down to the architectural anatomy of the pelvis.
Hmm.
The reproductive organs, the bladder, and the lower bowels all share the exact same tight neighborhood. They are just packed in there together. When ovarian cancer develops, it often causes something called ascites, which is a buildup of fluid in the peritoneal cavity, the space inside your abdomen.
So that fluid acts like an expanding balloon inside a closed box.
Yes, the fluid buildup creates massive intra-abdominal pressure. It presses upward against your stomach, which is why you feel entirely full after eating just 3 bites of a sandwich.
That explains the early satiety.
Exactly. And it presses backward against your bowels, causing changes in transit time, which perfectly mimics IBS diarrhea or constipation.
Unbelievable.
And it presses downward against your bladder, causing urinary frequency. The tumor itself is gynecological, but the collateral pressure derails the entire gastrointestinal and urinary system.
That structural perspective makes so much sense. It's fundamentally a space issue. And it really highlights why tracking the frequency, that 12 times a month rule, is so critical.
Right.
A bad takeout dinner gives you a stomachache for 2 days. A growing structural mass creates pressure that just doesn't leave.
Exactly. And while we are on the topic of structural problems, we really have to move from the internal cell symptoms to the external, tangible, physical changes. The alterations a survivor might actually discover themselves while showering or applying localized treatments.
Right. We've covered systemic symptoms and internal fluid pressure. Let's talk about the physical changes, lumps, ulcers, and what I see as the massive danger of the wait-and-see approach.
The Macmillan Rapid Referral Guidelines leave zero room for ambiguity here. Any unexplained palpable mass in or at the entrance to the vagina warrants an urgent 2-week referral.
Okay.
Furthermore, any unexplained vulval lump, bleeding, or ulceration must be seen by a specialist immediately.
But here we crash right back into that complicated baseline we established at the beginning. Because the sources clearly state that pelvic radiation can cause rare vaginal ulcers or sores simply because the tissues are so damaged and oxygen deprived.
Yes.
And it says these benign radiation sores can take months to heal.
They absolutely can. Because the blood supply has been compromised by the radiation fibrosis we discussed earlier, the tissue just struggles to mount an immune response or repair itself.
Right.
So a completely benign radiation ulcer can take an agonizingly long time to resolve.
So if I'm a listener and I know that a radiation sore can legitimately take months to heal, how long do I wait before demanding a specialist look at it? Do I apply the cream my doctor gave me and give it a month? 2 months?
You don't wait. That is the ultimate life-saving takeaway from these clinical guidelines.
Really, no waiting at all.
None. The protocols specifically state that any failure of treatment for benign conditions in these areas must prompt an urgent cancer referral to rule out vulval or vaginal cancer.
So if a general practitioner gives you a topical steroid or an estrogen cream for a sore, and it doesn't begin to resolve quickly, you escalate it.
Immediately. The rapid referral pathway exists precisely because specialists need to rule out malignancy first.
Right.
They use tools like colposcopes to magnify the tissue, and they take biopsies to look at the cellular level. They can definitively say, okay, this is ischemic radiation damage, or this is a cellular recurrence.
You cannot wait months hoping it's just radiation damage while a potential recurrence is growing.
Exactly. And the exact same logic applies to the bladder as well.
Very much so. Radiation and certain systemic chemotherapies can cause hemorrhagic cystitis, which is bleeding, and inflammation of the bladder lining. But blood in the urine, sudden extreme urinary urgency, or total incontinence are also the primary signs of a bladder or pelvic recurrence pressing on the urinary tract. The symptoms overlap completely.
They really do. And the only way to know is through specialized tests, like a cystoscopy, where a camera is actually inserted into the bladder to look directly at the wall.
It really reinforces the core message of this entire deep dive. Knowing your expected side effects doesn't mean you ignore them.
Right.
It means you understand your body is operating under extreme new conditions, and any new variable requires expert analysis.
The goal of discussing these guidelines isn't to make anyone hypervigilant to the point of daily panic. It's to provide a map out of the murky waters.
Let's recap that map for our listeners. We've covered the crucial dividing lines today. The absolute critical warning signs that demand a specialist review are: first, any postmenopausal bleeding. If it has been a year since your period stopped, any blood is a red flag, especially if you are on tamoxifen. Second, the 12 times a month rule if you have persistent bloating, early satiety, or pelvic pain more than 12 times a month. Demand a CA-125 blood test and a pelvic ultrasound.
Absolutely.
Third, the IBS trap. Any new onset of IBS-like symptoms in a woman over 50 needs gynecological investigation. And finally, any unexplained lumps, masses, or ulcers on the vulva or vagina that do not heal with standard treatment.
Perfect summary.
And remember that staggering statistic from earlier: 68% of survivors suffer in silence. You do not have to just live with the pain of tissue damage.
No, you don't.
Knowing these guidelines gives you the clinical vocabulary to walk into a doctor's office, describe your symptoms, and say, "This fits the criteria for a rapid referral, and I need a specialist." It takes away the fear of feeling like a hypochondriac.
It provides immense clinical empowerment. But, it also leaves us with an incredibly profound question to ponder about the reality of survivorship. Well, we have armed you with the clinical metrics, the CA-125 thresholds, the 12 times a month rules, the referral pathways. But what about the psychological toll of carrying this knowledge?
Oh, wow.
Yeah.
If you know that the symptoms of a deadly recurrence look exactly like a benign radiation tear or a frustrating bout of indigestion, how does a survivor navigate that mental labyrinth?
It has to be exhausting.
Exactly. If every stomach ache, every feeling of fullness, or every spot of blood could theoretically be the cancer returning, the hypervigilance could become utterly exhausting. So the question is, how do we balance the absolute necessity of medical vigilance with the ability to actually live, breathe, and enjoy the life that those brutal cancer treatments fought so hard to save?